right. Good afternoon, everyone. It is exactly 2:01, so we'll go on and get started. Dr. Katara Williams is unable to join us today, but she sends greetings. So we will go right into roll call. Ms. Gerald?
Yes, good afternoon. Roll call for today, March 26th. Dr. Sandra Brown,
Here.
Dr. Thomas Levis, I see him here, so.
What's that?
Dr. Thomas Levis,
The Health Equity Task Force.
okay.
All right, I'm
Dr.
sitting
Kim
down.
Hunter Reed, Secretary Kimberly Robinson, Dr. Adrian Wilson, Dr. Mary Meg Brown,
Here.
Dr. Ronaldo Banks, Senator Regina Barrow, Dr. Terry Davis,
Here.
Dr. Rebecca G., Miss Emily Remington,
Present.
Miss Carol Smith, Dr. Ronnie Whitfield, Dr. Gary Wilkes,
I'm here.
Dr. Damon Ijagiri, Dr. Eric Van Home, Miss Delesso Alford, Dr. Tavell Kendall, Representative Dustin Miller, Miss Alma Stewart,
Here.
Mr. Christopher Tyson, Dr. Derek Rivarius,
Here.
Dr. Corey Hebert, Miss Lenore Caroli, Dr. Keith Ferdinand,
Here.
Miss Sadie Finkel,
Present.
Councilwoman Helena Marino, Dr. Alicia Bates,
Present.
Dr. Janine Thomas,
Present.
Dr. Leanne Fowler,
Here.
Miss Cindy Snyder, Miss Kathleen Tate,
Present.
Miss Shalina Davis,
Here.
Mr. Michael McClanahan, Dr. Connie Arnold,
Here.
Dr. Faye Grimsley,
Present.
Miss Erica Rogers,
Present.
Mr. Frederick Thomas, Dr. Demetrius Porsche, Miss Judy Reese Morris, Dr. Earl Benjamin Robinson, Dr. Peter Foss,
Here.
Dr. Kathleen Kennedy,
Here.
Dr. Robert Maupin, Dr. Christy Anderson,
Present.
Dr. Takesha Davis,
Present.
Dr. Amanda Dumas,
Here.
Dr. Amy Leeson, Dr. Ebony Price Haywood,
Here.
Miss Dr. Margarita Eshaviri,
Present.
Mr. Christian Engel, Miss Tina Granger, Miss Catherine Haywood, Reverend Theron Jackson,
Here.
Mr. Rudy Macklin, Dr. Orlando McMeans,
Here.
Miss Erica Rogers, sorry, called her, Dr. Simone Rambati, Dr. Jacqueline Harris, Dr. Peter Kasmarsky,
I'm here.
Dr. Daniel Sarpong. If you're on the line and you came after roll call, I will look at the names in the chat and I will mark you present. That concludes the roll call, Dr. Brown.
Thank you. Welcome everyone to the Louisiana COVID-19 Health Equity Task Force meeting. This month marks the 1-year anniversary since the first case of the coronavirus was actually reported in our state. And next month will mark the 1-year anniversary of the governor's appointment of our Health Equity Task Force. So on behalf of Dr. Levice and myself, we thank you for your continued service. What began as a task has evolved into a mission with one intentional commonality, and that is equity for all. During the past few months, many members of our task force have been engaged in a variety of platforms, educating our communities about the vaccines, and we appreciate the meaningful work that you are doing. Our very own Dr. Levice, my esteemed co-chair, was featured on CNN and MSNBC. And so at this time, Dr. Levice, do you have any words of wisdom you wish to share with our task force before we dive into our agenda?
Well, with that introduction, I feel a certain level of pressure, but just to welcome everyone back and say that, our task is still not finished. We still have to get the rest of our people out of harm's way. This pandemic is still raging and there's still perils ahead. So let's get to work. I do want to also acknowledge Dr. Rivera's and that beautiful blue sweater that he's wearing there. But other than that, welcome back.
Y'all have your own little private code there. Okay.
Go Mob, my brother. Go Mob, brother. Go Mob.
All right. So today we have a robust agenda, and we are so excited to have such wonderful presentations that lie before us. We will have Ms. Tracy Gerald to monitor the chat box so that we can address all your questions. We will start with an update on the Louisiana COVID-19 vaccine. We welcome our esteemed guests in no particular order, Dr. Cantor, Secretary Phillips, and Ms. Neal. We also want to extend our gratitude to Secretary Courtney Phillips, who meets weekly with myself and Dr. Levice, providing us updates with concerning LDH. So at this time, we will move right into our update on Louisiana COVID-19 vaccine. And I'm not sure if Dr. Cantor will start or Secretary Phillips.
We're going to have Secretary Phillips start if you're on, Dr. Phillips.
I am on, but if you all can't hear me, please let me know. I'm actually at the vaccine site here at Living Faith in Baton Rouge, and so my service is not great. So I know I've been on several calls and had to get on mute just because of the interference. So just let me know.
Okay, we can hear you.
Okay, so I just wanted to just start off and really just thank the Health Equity Task Force for the work that you all have been doing from the start of COVID. I mean, we're pretty much at our year mark, and it has been just a heavy lift for the team LDH, for many members on the phone, but for the task force as a whole. And so really do appreciate y'all's efforts, being able to have individual conversation with many of the members. Dr. Brown alluded to the conversation that occurred. And so what you all are seeing in the community, what ideas you have for us, and just that partnership, I think really has helped us in the state move forward. We have continual work to do when we look at our vaccine rates by race, but I do think we see small improvements week over week. And that really is because of the intentional effort put forth by this task force, our partners, and the team members at LDH. So I really just wanted to start off by saying thank you for your efforts and your continued partnership with us going forward. We could not be where we are without you, and we want to make sure we continue this partnership. So I know we have some efforts we need to work on going forward, but we want to make sure you know that we're committed to that and that we appreciate y'all's efforts. So Dr. Cantor, I'll turn it over to you. Thank you.
Thank you, Dr. Phillips. Drs. Brown and Dean Levice, thanks for inviting us to join you again. It's good to see everyone. As Dr. Phillips said, we feel like we are making sustained gains, certainly not fast enough, but going in the right direction, which is encouraging. Overall, the vaccine rollout is going well. Today, we have 24.4% of the Louisiana population at least initiated the vaccine series, and about 14.6% of them having completed the series. And that's all ages, including people 16 and below who aren't eligible for the vaccine yet. That puts us slightly below national average, but ahead of almost every other southeastern state. So regionally, we're excelling. We clearly have work to do. There's no question about that. I'm going to come back to this premise in a second, but the tenor of this work is changing this next week. And up until now, we have been in a supply limited state. We have been limited in the amount of vaccine that has been allocated to us by the feds. And on some aspect, that probably buffered any access and hesitancy issues that were out there throughout Louisiana, because demand so far exceeded supply. Supply is picking up substantially starting this coming week. It will continue to do so in the weeks ahead. So it will not be, from this week going forward, an issue of having enough supply from the feds. We will have all the doses that we can use. It's going to be an issue of how do we reach people across the state? How do we allow people to have their concerns addressed, have their questions answered? How do we help people get to vaccinations, and how do we bring vaccinations to people? That's going to be where the challenge lies ahead. I mean, that always was the challenge, but when supply was so far short of demand, it was not as acute as it's going to be. So we really have the opportunity, and I'm not flippant about this, at some point in the next couple months to move this from a pandemic to an endemic. We genuinely we're going to have enough doses made available to us as a state to do that. What's going to determine how successful we are in that is how well we use those doses, how well we create the conversations that people need to feel comfortable, to feel empowered, how well we can reduce barriers going forward. The racial disparities in vaccinations still persist, although every week they get a little bit better. I would like them to get a lot better, incrementally better every week. So over the past week, the percentage of all vaccines in the state that have gone to Black residents has increased just a bit from 26.3% of all to 26.9% of all residents. The percent that have gone to white residents has decreased just a bit from 61.9% to 61.5%. It's been that way for the past 3 or 4 weeks. Incremental change in the right direction, just not fast enough. That's been a result, as the secretary alluded to, of really hard work, of partnering with communities, going out, really engaging on a ground level. And that's only going to have to continue and increase. The quality of the data has increased tremendously. And in this area, we are a clear national leader. We had come before this body about a month ago to when we initially were able to report on demographics. And Dr. Levis, you very aptly said the data at that point was unacceptable. We had 30 to 40% of vaccinations we did not know what race or other demographics were tied to it. That's where the national numbers remain. Nationally, 47.5%. There is no racial demographic information for vaccinations. Because of the work that the data team has done in LDH, we have brought that number to below 10%. So we have one of the highest quality data sets, one of the most complete data sets in the country right now, which will be important going forward because we're going to be delving in on a more granular level. As of yesterday, you can now go onto the dashboard and see vaccination administration information down to the census tract level, which is about as granular as it gets in terms of this type of mapping. You can see racial demographic administration data down to the parish level. That's going to be able to drive the outreach efforts that we're going to be focusing on. And I know Ali is going to come behind me and talk more about what that type of work is going to look like. Taking a step back and just talking about the pandemic, aside from vaccination, we made great progress as a state over the past couple of months. We had a big surge around Christmas and New Year's. We've come down substantially since then, but our progress the past couple of weeks has stalled. Dr. Fauci has been very clear that when he sees progress stalling in a state, he's worried about, the future rebound that could come. The worst region right now is the Lake Charles region. There's no question about that. Their percent positivity almost doubled this past week, is up to 11.6 or 11.9% right now. But we're seeing stalling progress in the Baton Rouge area and a couple other regions as well. We believe what is driving this is, on a small level, people's fatigue and just being tired of masking and distancing. On a much larger level, the variants, particularly the B117 or the UK variant. We've identified 164 cases of that variant in the state, but like everywhere else in the country, we just don't do a whole lot of this type of genomic sequencing. So it's a tip of the iceberg scenario. When you have 164 cases, you have many more. It's analogous to what it was like a year ago when we diagnosed our first case. Testing was so limited back then. In retrospect, we had diagnosed our first case in the New Orleans area, but many other cases were there. We just didn't have the capability of fingering it at that moment. The area with the most variants is the Lake Charles area. And because we know the variant is more transmissible, up to 50% more transmissible, we think it's driving transmission there. And we're worried that that's gonna bleed over into the rest of the state. Thankfully, the 3 vaccines we have authorized right now remain a really good match for the B117 variant. And in that lies our opportunity. If we can get vaccine out quick enough, I think we will avoid another surge. If we are sluggish in our vaccine rollout, we're going to be at risk for one. And I think it's as simple as that. To that end, and speaking more to what needs to happen to get more vaccine out, again, supply in the very near future, really this coming week, is just not going to be the limiting factor for us the way it has been up until now. It's going to be our ability to get into communities, our ability to empower people to get their questions answered, have the conversations that we know they need to have. And focus group after focus group, and I want to particularly thank Shalina for the work that her team has done on the last round of this. Each focus group tells us that there is immense opportunity in there, because what we are not hearing a lot of is, I don't want it, I'm never going to get it. What we are hearing a lot of is uncertainty, people working through their concerns. I don't know, I'm on the fence, I want to wait and see, I want to talk to my family, talk to my friends. That's much more commonly heard as the refrain, which tells us there's an opportunity there that we need to capitalize on. But Lord knows we can't do it alone. So a lot of partners are going to be involved. The campaign that Alex is going to talk about is going to be critical to our ability to get from where we are now, about 25% coverage, to where we need to be, which is 60, 70, 75% coverage. It's going to be possible to us. We'll have the doses. It's just going to take a lot of work to get there. I'm going to pause there and ask Ali to give us a quick briefing on the Bring Back Louisiana campaign and where people can fall into that.
Happily. Thanks for the setup. Thank you all for this opportunity, and thank you for your continued leadership and your partnership in this urgent mission. And we also very much see it as a mission. As Dr. Cantor just said, we have a lot of work to do, and the work does get harder. And it was really the birth of this campaign that we're about to talk about. It's, we understood the need for what we're calling Louisiana's ground game for the vaccines, the need to be collaborative, the need to be unconventional, the need to be creative. And there does seem to be, I don't know if you all are seeing it in, at least in the media too, both in Louisiana and nationwide, a growing consensus that these types of efforts to meet people where they are absolutely needed. So excited to update you all, and excited to have you all as a critical partner in this effort. So I am going to pull up my slide deck in just a second. But just to say that, the last time that we updated on this campaign, a lot has happened, and I won't go over the same updates that Dr. Phillips and Dr. Cantor just went over, but to say, we've doubled the number of partners that are now part of this effort. We're now 22 partners strong, which is pretty incredible, and I'll show you that list in a second. The last time we spoke, we also were still wondering whether or not we had the capacity to take on more than one pilot. Now we're talking about 9 pilots. Last week, when the governor announced our bold grassroots campaign, Bring Back Louisiana, which is really focused on meeting people where they are and breaking down barriers on the COVID vaccines, we announced ambitiously that we were taking on nine initial pilots and that we would grow and learn from there. Then this week, as you all saw, we not only expanded eligibility significantly is not even the right word, but we also announced more progress on the campaign front. We identified zip codes, the zip codes of those first 9 pilots, looking at a number of factors, including social vulnerability defined by the CDC, their index, as well as looking at our least vaccinated areas by Census Tract, and then also looking at disparities, including in terms of race, and then also just looking at some intangibles, like how the rollout has gone to date, according to our regional medical directors, who are obviously in community. And then yesterday, I believe, Dr. Cantor might have mentioned this, we also publicly shared vaccination data by Census Tract. So, and we know that breakdown is really important for you all, for our other stakeholders and partners, and for the larger public. So I'm going to jump on my slide deck to show you. Okay. Here we go. Okay, so you all have seen this. And you've seen this too. This is our mission. Again, really focused on breaking barriers so everyone has the opportunity. We know that people don't want to be persuaded. We know that people have valid questions and concerns, and we want to meet them where they are and answer those questions. We want to have personal conversations. I'm going to jump through, not going to focus on goals today. This is our list of partners to date. I can't even go through the number of additions since we last spoke. The most recent additions are United Way Southeast Louisiana and Resilient Louisiana Commission. So I'll move from there. This is a model that you've seen before, just to go over really quickly. It starts with identifying data, as you just heard me update on, using our data to identify where we're going to go, looking at a number of different factors. And then once we do that, we plan events. We bring actual vaccine allocation to those communities of concern. And then we work with community partners to wrap around those mobile units, those clinics, whatever it might look like. We wrap around that, get out the vote type tactics, really targeted outreach leading up to those events. Here are a few updates since we last spoke, and I'm really going to focus on the third item. So I mentioned, I walked through data a second ago. We had our second partners meeting earlier this morning, and it's just a very energizing group and conversation. So heard a lot from partners in terms of all the great work that you all are doing, that others are doing in this space, and what everyone really can bring to the table and leverage so that we can accomplish this very urgent, very big mission. We continue to map out this week and throughout next week, just individually with partners, what everyone's reach, scope, and role can really look like in this effort. Because again, it's a large, diverse group, and we know we need everybody in this fight. And then lastly, this is something we'll announce next week that we're really excited about. And again, is part of this overall campaign to break down barriers. And we know there are several barriers to the vaccine. One of them is access to internet, access to information, the privilege or the time to be able to navigate what can be a cumbersome system for scheduling appointments. And so we are standing up a vaccine call center. And what's really cool about this is that, and it's an elegant solution, is that we are essentially cross-training our existing contact tracers who do have a lightened load right now, because thankfully of our good or stalled, as Dr. Cantor would say, COVID trends, who are able to be cross-trained and pivot to vaccine, or able to take calls from the public on the vaccine and do things like answer questions they may have, but also probably most importantly, actually schedule appointments, not just point them to the website, not just point them to 211, who can very helpfully answer questions but cannot schedule appointments at this time. They also will be able to connect individuals with medical professionals for any specific questions they may have about their medical conditions and related to the vaccine. We know that medical professionals are among the most trusted sources of information, so it's important that we are able to do that. So it'll be cross-training 50 contact tracers and an additional 10 clinicians who actually are call agents. And it will be working from 8 a.m. to 8 p.m., 7 days a week, potentially reduced hours on the weekends. And again, we will announce this next week. We hope to have it stood up by the end of next week, early the following week. Here are the pilot programs that you all, I hope, have seen already. These are the zip codes. Again, for these very initial pilots, these will increase and grow. What we will be doing, as I mentioned before, is zeroing in on census tracts and announcing that next week. These are materials, which I believe you also have seen, push cards, very early push cards that are now going to our existing community vaccine events happening around this, really focused on trying to empower those who have just gotten their vaccine to go share their story. We know that friends and family are among the most trusted sources of information. Getting individuals, we have a lot of Louisianans who have gotten the vaccine, want to empower them to go tell their story, share their experience with others in their lives. And here's just a sticker that we are giving out as well. And with that, I'll stop and happy to take any questions or feedback.
Allie, this is Sadie. I just wanted to say, I noticed that you guys have hours of 8 a.m. to 8 p.m. I just wanted to say, I think that's really important to have, resources outside the scope of a normal 9 to 5 workday. So thank you for thinking of that as well.
Absolutely. And I want to give a shout out to New Orleans and Nola Reddy in particular. We were just doing this on our partners call too. We've learned a lot from what's going on in New Orleans. Truly a leader in these types of grassroots efforts. So really great partner. Continue to looking forward to continued collaboration.
I want
I had a
to.
question.
This is Terry Davis. I want to give a shout out to John Van Cherry and Shreveport, because at the fairgrounds and at Chevyland, they have multiple lanes and extended hours based on community input of needing extended hours. And the FQHCs up here are also doing a swell job.
I had a question. So with the new data that was recently released at the census tract level, as you might predict, there's a lot of media interest. In fact, I just had a phone call with the advocate here in New Orleans asking about it, and I deferred because I wanted to have this meeting first. But maybe you can provide us with your thoughts about how you would address the question. So as I look at the map that they sent me, it's clear, looking at the vaccination rates by census tract, it's predictable which tracts have the lowest rates. I mean, you could substitute out the words COVID vaccine for pretty much anything. You could substitute it for hypertension, you could substitute it for homicide, you can pretty much name a cause of death, and it's the same communities. So how would you answer the direct question, why is it that these specific neighborhoods are having such a difficult time getting people vaccinated? And what is it about these communities? So we clearly can't make an argument that this is a biological or genetic thing, because it's every possible health outcome, and it's the same neighborhoods. How would you respond to that question?
Dr. Cantor, you want to take that, or you want me to?
I can start. That's like, I mean, I don't know is the honest answer right now. I mean, clearly the social determinants of health are at play here, and we have our work cut out for us. I mean, I honestly don't know. It's a question that I ask myself all the time, and it really pains me to find a good answer, because you're absolutely right. It's not, COVID is just what's happening now, but you parse it across any outcome you want to, and the data is very similar. You know, putting this data out there, it's not pretty, you know, and it raises a lot of questions, rightfully so. I mean, that's the reason why it's out there, is because it's, you know, it's now it's there. Now we got to go fix it. You know, now we got to go at it. But for the larger issue, I really don't know. I mean, I'll tell you, that aside, outside of New Orleans and Baton Rouge, the demographics play some other elements to it. And, you know, there are real disparities amongst conservative whites in other parts of the state for vaccine uptake that don't tend to be along social determinants of health lines. There's a political aspect, and that's something else that, you know, the state's going to have to look at. But I think you're absolutely right. It's indicative of the underlying problem. And the underlying problem is more acute in Louisiana than it is in almost every other state.
Any other questions? Are there any questions in the chat box? No.
I had a question about the distribution. You know, a few weeks back, yeah, our Community Outreach and Communications Committee, we started talking about the distribution being done at churches and community centers and places of that sort.
Think you froze, Dr. Riveras.
Let's see if there are any other questions, and then maybe
Right.
he'll get unfrozen.
There are no questions in the chat box.
I'm sorry, this is Dr. Wilson. Do you have the map with the hotspots that you are alluding to? Is that going to be made available? Because one of the other committees I'm on, the Tackle Committee, you know, we have hotspots as far as cancer, rates of screening, and I'd be curious to see how some of these things overlay with some of the other issues that we're looking at, some of the other health disparities, to see just how they really are overlaying. Are you going to make that available to the whole committee?
Yeah, Dr. Wills, it's actually public. It's on the public dashboard, the coronavirus.la.gov, and there's a number of different views you can look at. It'll start off with a regional view, and if you zoom in, it'll go to a parish view, and if you keep on zooming, it'll go to a census tract view. And if you click on the percentage number, that percentage number is the percent of that population vaccinated. If you actually click on that number, it'll bring up a box with some other information on that.
Okay, I'll look it up again. All right, thanks.
All right. Dr. Rivera says his power went out, so he'll try to see if he can join us back.
It's not good.
Yeah.
Dr. Brown.
Yes.
Hey, Dr. Brown, it's Christy Anderson. Good morning. Good afternoon. I just wanted to ask a question about, I think last meeting that we had, I think it was Dr. Banks that talked about having access to the vaccine in his clinic. And I just did a focus group with a couple providers in Opelousas that said that they had signed up to receive the vaccine. One is a pediatrician, and since her, since the new age is 16, some of the patient's parents have called and said that they'd rather their children get the vaccine in her clinic, but she's not received any feedback. And another was a family medicine practitioner who wanted to have the vaccine in his clinic as well. Is there a process that I can, pass on to them about what it is that they need to do, or can I submit their names, or, what can we do?
Yeah, absolutely. The process starts with the applicable regional medical director, who is looking at the area from their perspective, and up until now trying to move what was very limited supply to the areas that were best suited to take that. And sometimes a potential provider is next door to another provider, and does it make sense to supply both? Those conversations start with the regional medical director. If anyone needs help connecting with their regional medical director, that can happen through me, or I'll volunteer Dr. Earl Benjamin or Allie, or really any of us at LDH can connect with the regional medical director. I will say those decisions about how to triage the very limited supply are going to become much, much easier to make in the weeks coming forward as supply increases. Won't have to be, so it'll be a much easier process. More providers will be able to be supplied. The other side of that I should just mention is, we were very intentional in telling vaccine providers that they could not discriminate on any basis, including their own patients. So up until now, when a vaccine provider, when a potential vaccine provider came to us and wanted to receive vaccine, we said, listen, the rules are you will become a public resource. You'll put your information out there. You will need to provide vaccine to anyone in the community who is applicable. You can't just say, I'm only going to do it for my own patients. And there was real equity reasons behind that statement. We did not want vaccine providers or hospital systems saying, this is only for my patients and no one else. But that had the unintended effect of boxing out some primary care clinics and some pediatrician offices who don't have the means anyway to be a community vaccination site, but would like to have it on hand to give to their patients. As supply picks up, that's something that the department will be looking at when the right time to lift that restriction will be, which I imagine will be in the interest of a lot of small clinics like the one you're mentioning.
Okay, we see Dr. Rivera's has joined us back. Welcome back. You had a question?
Yeah, and I want to give my neighbor and friend David Stamps a heads up. We just had a quick power outage. He lives not far from me. I don't know what that was about. It went on and went off and came back on. I was saying that we have been able to distribute the vaccines in community centers and churches, and that's great. Talking to a friend earlier this morning whose father works in a food processing place where there was an attempt to deliver the vaccines. Have we been able to target those kinds of places to go to where the people are? I know I saw an article that said something about vaccines for shrimpers and others, especially those folks in the rural and remote areas.
Thanks, Mr. Rivera. Not to the degree that we would want to. And that's something that we're going to be looking to do going forward. We have the assistance of a number of National Guard teams to do mobile vaccine events on site. But that's a limited resource, and we're trying to send them where they're most needed. It would essentially be the same team that would go out into a community at a community center as it would be that we would send in to a business or a place of industry. So those will start happening, but we're trying to balance that resource with all the needs that we need to send these teams to do. But yeah, you're absolutely right, and it's there are equity issues there too, and access to care, and the risk of transmission in a lot of these industrial settings is quite high.
All right, are there any other questions?
This is Orlando. I had I guess more of a comment and a question. I was wondering whether or not you've been contacted by USDA. I know there's a big push for supporting Black disadvantaged farmers. And I think as a part of that $1.9 trillion package, I think part of that funding will be available for especially rural America, but specifically Black, minority, disadvantaged farmers. So I wonder if the state of Louisiana has heard about these resources, or have they been availed to you?
I personally have just know that the headline, and I have not seen any fine print on that yet, but I'm looking to get that information.
And I'm looking into it also.
Yeah, thanks, Amanda.
Okay, there's a question in the chat. Ms. Tracy, or?
Yes, it's from Ms. Erica Rogers. Would that be the same process through the regional director for grassroots organizations who can reach the people, where they are to become community partners for vaccine?
Yes, yes, it absolutely is, and that's an ask that we want to make to community groups, is that if you have either an identified need that has not been addressed, or if you think you have a role to play in helping bring vaccine to communities, particularly marginalized communities, that you reach out to the regional medical director and discuss how to make that happen. Absolutely.
Okay. We thank you, Dr. Cantor. We know you are so busy, but we certainly appreciate your transparency and you're willing to share real-time data as you get it. Allie, continue with the great work that you're doing. And I don't know if Secretary Phillips is still on, but we appreciate her joining us as well. Thank you, and we'll have you again to give us an update at a later time. You're welcome to stay, or you can leave. It's up to you.
Thank you for joining us.
Next on the agenda is a report on the Black and Essential study that was conducted by the LSU Manship School of Mass Communications, made possible through funding from our donors, Pennington Family Foundation, the Baton Rouge Area Foundation, and the Huey and Angelina Wilson Foundation. And I think representatives from all these foundations are on the call. We'll start with Dr. Janae Slocum, Director of the Riley Center for Media and Public Affairs. She will give some background information of the study, and then we'll hear from Dr. David Stamps, who's the principal investigation of the study. Dr. Slocum.
Good afternoon, members of the COVID-19 Health Equity Task Force and other audience members. We're really excited to be here today to share the findings of the Black and Essential study. My name, as Dr. Brown mentioned, is Janae Slocum, and I am the director of the Riley Center for Media and Public Affairs at the LSU Manship School. You can think of us as the outreach and engagement arm for the school. And in particular, we help to connect our scholars and our students with, or rather connect their work with the community. So when stats started coming out, I believe it was in April, because Louisiana was really ahead of the game on the effect of COVID. Forgive me, those are my animals. The COVID-19, how it was affecting the Black Louisiana community came out, and Dr. Stamps immediately contacted me and our former dean who passed away, Martin Johnson, about how he could apply his expertise to helping to guide policy and resources to support Black Louisianans, especially around decisions that are made, in crisis, and this crisis and future crises. We're grateful to this body for choosing to fund this work. With that, I'm pleased to introduce Dr. Stamps. He's going to present the results of this work and also how we will continue after this meeting and release to get the information into the hands of the people and organizations who are doing the on-the-ground work of both vaccination and serving this population within our state. His primary research focus and expertise, among many, is aimed at understanding the psychological and behavioral effects of identity-focused interpersonal interactions, as well as individuals' exposure to and engagement with media. And I think that as he presents his findings, you will see how those interests intersect with this work. And with that, Dr. Stamps, would you share what you found?
Sure. Thank you, Dr. Slocum. Hi, everyone. Again, my name is Dr. Stamps. I'm a professor at LSU's Manship School. Thank you to all of the funders and to you all, the task force. We began this conversation back in June, July, which feels like it was decades ago. So just kind of a quick overview of what brought us here. So as Dr. Slocum mentioned, as a new Louisiana transplant in the midst of COVID, and then just hearing the numbers of how Black communities have been impacted in such an adverse way, I really wanted to do something. And I wanted to do something that would add to the conversation and enrich those of us who are looking to understand what's happening, and then also how do we set up communities to survive and thrive post-COVID. So what I had proposed was to gather data that would be helpful for local organizations throughout the state that really could speak to the lived experiences of Black Louisianans across the entire state and really bring some of those intersectional voices to bear. The great item was a lot of folks here on this task force weighed in on those measures and wanted to make sure that we address reflexivity and validity, and that we were able to capture those voices authentically so that we can have some data that really can speak to what do we do post-COVID. So with that said, I'm going to share my screen so we can have some visuals. You can follow along with me. And if I'm not mistaken, the full report and the executive report were shared, and we'll also have a link if anyone want to have access to that. So let me pull something up so we can take a look collectively. There we go. So the idea when I initially started was to launch the Black and Essential Consortium. And the idea is to bring those voices that may be missing and absent from the conversation, and to have open-ended engagement to find out how our communities, again, surviving and thriving COVID and what we can do post-COVID. So I think this is a great segue, as the presenters before me spoke to the vaccine rollout, the decrease in hesitancy in reaching into certain communities. That is an amazing conversation. So now I want to engage with what can we do collectively as a state to set up our communities that were arguably in harm's way before COVID, and that has been exacerbated by COVID. And then now as we start to turn a corner, how do we give them the tools so they're set up for success? So just a quick overview, and many of you are fully aware of this, that in the state of Louisiana, as of this month, while Black Louisianans make up 32% of the population, they're roughly 55% of the population when it comes to hospitalizations, contractions, and death. Right now, Black individuals in Louisiana are 1.7 times more likely to be impacted by COVID compared to their white counterparts, which is a little under the national average. What's unique about us is that hypertension and diabetes tends to be the gross comorbidities that Black folks are facing across the state. But here, it's actually air quality and different forms of environmental racism that are impacting our Black communities. And I'm pretty sure you all know this, many of you are from Louisiana. Things from Cancer Alley to Red Line that have put a lot of our Black folks near chemical plants. And so it's a unique way in which we look at our populations that are kind of standalone. And from a very general macro perspective, Black communities compared to our racial counterparts are more likely to live in food deserts. They're more likely to lack access to clean water, housing insecurity, evictions. So this research is very intentional to bring forth a narrative of why we need to focus in and look post-COVID in the ways in which we're going to navigate. So with that, it's a grander project that is still ongoing. And initially I collected data from about 300 Black US residents to kind of get a sense of how folks were doing. From there, I moved locally to Baton Rouge with about a population of 500 to get open-ended data to understand some of the narratives. And then thanks to the generosity of this task force and additional nonprofit organizations, I was able to collect data from over 1,000 Black Louisianans to really understand how those different variables are impacting us and ways to move forward. As you can see here on the slide, the mean age was about 30, so it skewed a little younger, but the range was from 18 to 27, so 18 to 72. So we
Maybe you need to advance your slide.
Advancing your slide.
Showing.
I'm sorry. It's not advanced. I'm so sorry. And you would think because I do this teach for a living, I would be okay. Can you see these slides okay?
Yes.
Okay, so I'll just hold it right here. So sorry about that. So as I mentioned, for the work that we did right here, specifically, we collected data from over 1,000 Black Louisianans, median age about 30, but a range of 18 to 72. So we were able to capture some robust data here. We also brought in 4 community partners in New Orleans and Baton Rouge that looked at all of the raw data, looked at the actual write-up that you all have in your inboxes to really make sure that it was valid. In full transparency. Like many of you, I hold advanced degrees. I live a moderately comfortable life, which is fantastic. But when we're talking about narratives, it can't just be one narrative. And so capturing data that reflect the diversity of our Black population and then bringing in community partners to really critically engage with that data was really important. And thank you to the committee members who really pushed to make sure that that happened so that as we engage in these conversations, they're reflective of the spectrum of Black identities. Moving forward, some of the things that came out of this research that I think would be really important for all of us. So as you can see here, I looked at what's happened in the home of Black Louisianans, the type of financial resources that have been received since COVID began, and I'll break these down. So in the home, out of the 1,000 individuals, 37% has someone in the house that has serious health conditions, putting them at risk. 27% has someone in the home that worked in a healthcare setting. So again, a nurse in a hospital, along those lines, again, high exposure. And then 38% has someone in a house that identified as an essential worker, specifically working in fast food or grocery stores. So our Black population across the state are well represented in certain facets where they have increased opportunities for exposure. Likewise, of the sample population, 48% received the first round of stimulus, 32% received SNAP, 27% received Medicaid assistance, and then going down the line, you can see here unemployment payments, Social Security benefits. And so the resources, the financial resources have actually flowed into the community, but as you can see from these percentages, they're not at a large scale. And then from a community standpoint, 19% of our population received financial support from family and friends, had to visit food banks, and had support from nonprofit organizations or faith-based organizations. What's really interesting about this data I want to highlight is roughly 20% of our population, and if we expanded that, that's a large number, receive 4 or more of the financial benefits that I've listed here. So Black folks in Louisiana are leaning heavily on financial assistance, and I don't want that to be missed within this data. Although that's not the driving factor, folks are hurting, and we need to have that conversation as we think about programs and policies and funding being allocated. However, one of the really key things that came out of the research and what I kind of hang my hat on with this project was looking at technology access and technology use. And this is not only important for the Health Equity Task Force, but for the Communication and Messaging Subcommittee and other subcommittees as well. So I'm glad to share this data and to have this readily available for folks. And so as you can see right here, specifically when it comes to access, 87% of the population had internet in their private residency via smartphone, laptop, or tablet. 77% had access to a laptop, 48% to a computer. And interestingly, 92% of Black Louisianans have access to a smartphone, which means that when it comes to getting messaging to people through technology, this is a unique way to reach folks. And it superseded specific general locations in Louisiana. But to build on that, because it means one thing to have access to technology, but it's another to have the literacy to use that technology. Only 28% of the population had used telemedicine. That means that they were able to reach out to their doctors using the video conferencing software, similar to what we're using right now, or were able to engage with getting access to their prescriptions via using websites and smartphone applications. So there's a big drop between having access to technology and being able to use that technology appropriately. And then also, you can see here, 31% has ordered prescriptions and 58% had used smartphone applications and websites for pickup services at grocery stores or through Amazon. So there is a gap between having access to technology and then having the literacies to use all of the interesting aspects of that. And so with that data in mind, I really wanted to dig into our population and see if Black Louisianans have access to technology and they have the literacy to use it appropriately, And what other ways might that benefit them? And the research showed that when you have access to smartphones and tablets and you know how to use the website and how to navigate smartphone applications, there's an increase in personal growth and efficaciousness and social mobility. So not only can we close the gap between access via technology, but Black folks feel better, do better, and engage more in their community when they feel efficacious. So we're looking at a very practical and then a very kind of cognitive mental standpoint that benefits communities. So, and I'm 2 more slides hanging there with me to wrap this up. What I really wanted to kind of hang this data on was the idea that when it comes to public health messaging, which I think was fantastic in our last presentation, was that 92% of Louisianans have access to smartphones. 87% of the population has access to internet. That matters when it comes to getting information out to them, whether it's social distancing or vaccines or using digital technology to close the digital divide. Likewise, those smartphones and technology place us in an interesting space to where if we need to social distance, you're still able to see your medical provider using third-party video conferencing. You're still able to get your prescriptions by having that particular prescription sent to CVS via the World Wide Web, and then having that delivered to your home. And so there are ways in which we can engage with digital technology that allow Black populations to stay safe. And as my research has already shown, it also has positive impacts from a cognitive and affective and behavior standpoint as well. Which leads me to my very last slide, the idea of what technology use and application means. What it means for us is digital literacy. This idea that it's one thing to just actually have software and hardware, it's another to know how to navigate it and use it appropriately. And so I highlight this idea that if everyone has a tablet, if everyone has a smartphone, that's fantastic. However, if you don't have strong Wi-Fi, if you don't know how to navigate FaceTime, you don't know how to navigate video conferencing software, then it doesn't really benefit you a great deal. And so as we move post-COVID, as everyone gets vaccinated and we try to find what new normalcy looks like, how do we set these communities up to survive and thrive? Because I personally believe that we're not going to go back. There's going to be a rich conversation of the luxury of having video on demand and using FaceTime to connect and using telemedicine to engage, especially if you live in a space that's a medical desert. Now you have this rich, unique way to engage with your doctor and don't have to catch the bus anymore or don't have to rely on public transportation. Again, mitigating the risk of certain types of viruses that could harm Black communities. So the last thing I highlight in the report is the idea of building on partnerships, training centers, and redistribution of resources with an emphasis on community resilience. So let me kind of walk you through that briefly as we wrap this up. We have a plethora of high schools and community colleges throughout the state, young folks who are very tech savvy and who are going to enter a workforce that is somewhat bleak in the midst of COVID, and rightfully so, this is where we are right now. But what if they took those skill sets and were trained to teach those to their communities, partnering with churches and community centers around the state to make sure that everyone knew how to use technology and understood the benefits of it, as far as engagement, allowing for social distancing, allowing to mitigate the digital divide, and even more importantly, allowing them to have access to resources they didn't have prior to COVID. And so with that said, the next steps for this research, and thank you all to the committee and to the donors who made this possible, we're going to start to kind of blow this out and really look at what it means to partner with local organizations, what it means to kind of build those relationships with community colleges and high schools, to really put forth an effort to make sure that the digital divide can be addressed so that whatever those needs are, whether it's to go to Talkspace because mental health is an issue, or you need to have access to your doctor because you've had hypertension, you've had high blood pressure, but your doctor wants to check in quarterly and refill your prescriptions, and you don't want to get on a bus or you don't want to have to drive a long distance because you live in a medical desert. Now, third-party video conferencing and telemedicine closes that gap. You get the resources that you need in a timely manner through tools that are readily available that really help to mitigate some of that risk. We know in the midst of COVID that's important, but I argue post-COVID that will equally be important. And so the next step for this project is to reach out across the state to local organizations, share with them the executive report, the full report, and entertain conversations where we can talk about how this may be implemented, putting together a resource guide, putting together different teaching tools. I am a professor by trade, to work with young people who can now start to teach those classes and build their resumes for a more competitive job market post-COVID, but also to enrich our communities so that they can understand all of the different opportunities and applications that exist that makes them more efficacious and really builds on community resilience. I know I had limited time, so I went really fast, but thank you all so much, and I'm happy to take any questions.
Yes, there's a question in the chat as to how the information was collected for the survey. Was it online or telephone?
That's perfect. It was all done online, but we brought in three different third parties to help us collect that data to make sure that we can cover as much of Louisiana as possible, but everything was done online.
Dr. Stamps, who around the state, so we have 9 health districts. And so some of the health districts are very, 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 very poor, and some of them are very rich with resources. Do we know where the bulk of the individuals who answered the surveys came from? Can that be pulled from the data? Because I know in the Delta part of the state, there is not a lot of people using the internet because there's just weak access there. And so I think the information that you provided is rich, and I like the direction it's going in. But I would be interested to see where the individuals who answered the survey, where they're from and where they reside inside the state.
Yeah, that's an amazing question. So I'm not from Louisiana. So even the use of parishes has been new to me in the last 2 years. So I have a list of all 1,067 individual zip codes. That's how I was able to kind of make sure there's some diversity. I don't know which parishes they're located in, but I'm happy to share that information. So I was able to capture that. But again, I've been here about 2 years, so I would need some help kind of geo-targeting where exactly it is in the state.
Okay.
This was an outstanding presentation, Dr. Stamps, and I think you drove home the concept that we all know. Because you have a phone doesn't mean you are health literate. Because you have advanced degrees does not mean you understand. So I think you've embarked on something very, very novel, but also very necessary to further study. And so very well done on the preliminary information that you've provided to us. You're welcome.
And this information is available for anyone. If you need any additional information or have any additional questions, please do not be shy. And I look forward to reporting to everyone which community partners, which organizations, and which media outlets we were able to partner with to disseminate this information and ideally, hopefully, walk out some of these plans.
Thank you. I think we'll be able to post what you're going to make public thus far on our health equity website, so everyone will have access to that report. Thank you again. Okay, at this time, we welcome the Nursing Home Subcommittee. The Nursing Home Subcommittee has continued to meet almost weekly, and they will present some preliminary findings of a study that they conducted titled The Lived Experience of Louisiana's Nursing Home Administrators During the COVID-19 Pandemic. So we welcome Dr. Alicia Bates and Dr. Janine Thomas, who are co-chairs of our Nursing Home Subcommittee.
Good afternoon, everyone. I am going to try to share my screen. Can everyone see it?
Yes.
Awesome. All right. Well, good afternoon. As Dr. Brown said, I'm Dr. Alicia Bates. I, along with Dr. Janine Thomas, we are the co-chairs. We also have 4 additional members in our group: Dr. Leanne Fowler, Dr. Kathleen Tate, Miss Cindy Schneider, and Dr. Lisa Van Hoos. And I would just like to say thank you to all of our members right now for their continued commitment and work in our committee. I'd also like to thank and acknowledge our executive leadership, Dr. Brown and Dr. Levice. So today we're just going to take a moment to kind of go over what we've been doing for the past year. And it's kind of crazy to think that this has been in implementation for a year. So as we know, at the beginning of the pandemic, greater than 40% of all of the nursing home deaths across the state of Louisiana was in nursing homes. And this was a very alarming statistic, and it continues to be a concern. However, we are happy to state that as of March 7th, 2021, and this is data pulled from the CMS, there have been 2,678 nursing home deaths, which represents about 27% of the overall state's death rate. So it is on the decline, but it's still definitely a concern. So as I mentioned, initially when the pandemic was first starting, data was very limited. All that we had was from the LDH, and it was really kind of generic aggregate data. And so now the CMS has a dashboard that you can actually go in and look at the resident cases per state, as well as the resident deaths per state. And so as of March 7th, we have about 12,564 cases in nursing homes. And then, as I mentioned, we have 2,678 deaths. Now, if you compare that to the total, which I put in parentheses across the nation, we are about 2%. Louisiana represents about 2% of the resident cases and deaths. The LDH also, since COVID first started, a lot of the frustration was that we could not get enough data, not enough of the demographic data. And so now we actually have this table that's on the LDH website. And while it does kind of speak to ethnicity and the nursing home deaths, and it gives you kind of an aggregate total, it still would be nice and more useful for us if we knew the actual resident demographic census. So like if we knew what was the percentage of African Americans in that facility, or the percentage of Asian Americans, or the percentage of other ethnicities, so that we could really get a very good picture of what was going on. Because it almost seems as if from this graph that African Americans are faring pretty well, when in actuality, maybe there's not as many African Americans in that nursing home, therefore their percentage is going to be lower. But it could also mean that maybe there's a lower percentage of African Americans in the facility, yet all of them are not doing well, they're passing away. So we just need a little bit more complete data, demographic data from the nursing home facilities about how many of each race is in that particular facility. So we have been pretty busy as a committee, and I'm just going to take a brief moment to kind of talk about our progress, and then my co-chair, Dr. Janine Thomas, will go a little bit more in depth on the different steps. So as we know, initially we came up with some recommendations that we presented to the governor's office, and we titled it the 3 T's plus the double C's. That was kind of our platform. We wanted to look at testing, tracking, trending, and also compliance and capacity. So our first recommendations were based on that platform. After we submitted our initial recommendations, then we decided, hey, we need to hear from the community. So we had a nursing home administrator actually attend one of our meetings. And it was a very good conversation, very robust discussion, which further kind of validated that we should eventually do some focus groups where we can speak with more administrators across the state of Louisiana. So in the meantime, we also worked on writing a manuscript, which Dr. Thomas will kind of go into the title of that in a moment. And then we started to begin the process of our research. So we submitted our IRB application, and once we were approved, then we sent out our first survey. And we'll also show you a little bit about what questions we asked. Of course, our survey related to our platform, we asked specific questions about the testing, the tracking, the trending. This survey was sent via email to, I think, approximately 278 nursing homes across the state. From that survey, we were able to garner some participation in our focus groups. And so we started to set up sessions where we had, 2 to 3 administrators to join the focus group, and we asked specific questions. After that, we realized, okay, the vaccine was in production. We were starting to administer the vaccine. So we developed another survey specifically asking administrators about vaccine administration in their facilities. And then we are still in the process of our research. So we have very, very brief preliminary findings, but hopefully our follow-up presentation will go into more depth about what we've discovered. So now I'll give it over to my co-chair, Dr. Janine Thomas.
Dr. Bates. As Dr. Bates discussed, we wrote a manuscript that summarized the initial work of the subcommittee and our platform. The title of the manuscript is The Disproportionate Impact of COVID-19 Had Upon Louisiana Nursing Home Residents from the Outside Looking In. It is still pending publication at this time. Next slide. The initial COVID-19 survey was created to obtain a better understanding of the testing, the tracking, trending, capacity, and compliance issues that were occurring in Louisiana's nursing home. The survey had a total of 11 questions and an option for administrators to leave their contact information for focus group participation. Although the initial response rate from the survey was only 16.5%, which was a sample size of 46, we were able to identify the potential administrators to participate in the focus group. On this slide, there are 3 questions from the survey. Question 5 is how is the facility promoting socialization for the residents? The use of technology was 97.44%, followed by modified recreational activities at 82.06%. Question 8 was what changes have staff identified among residents who have limited visitation with family and friends? Emotional liability was number 1 at 88.5%, followed by withdrawal at a 67.7%. Question 11 was if the facility has sufficient funding for additional equipment, what items would be purchased? Thermal detection equipment was number 1 at 59.4%, followed by portable sterilization tools at 54.05%, and additional purchases are listed. The purpose of the focus groups was to share their living experience during the COVID-19 pandemic. Initially, electronic invitations were emailed to a total of 15 administrators that identified themselves as willing to participate in the focus groups. Additional phone calls were conducted to garner participation in the focus groups, and the dates are listed in which we conducted the different focus groups.
We're hoping to do 1 or 2 additional ones as well. So we're still working on dates for those.
And as we were involved in the focus groups, there was information that was becoming available about the vaccine. So at this time, by the February 5th date is when the vaccine survey had been emailed. So thus far, we had a total of 8 administrators participate in the focus group sessions, representing 4 different regions across the state, which is shown on the map. Representation on the map is accurate for the regions, but random says your locations within the region to protect the focus group participants. The focus group questions were based on 3 different time frames, the past, the present, and the future.
Mm-hmm. And just to clarify, on our map, the push pins are actually where the participants, what region they were in. So
the vaccine survey was developed and distributed to all nursing home administrators to assess the vaccine availability, acceptance, and administration. There were a total of 10 questions on the survey, and there was a 26% response rate, which identified additional nursing home administrators for participation in the focus groups. This survey was administered on February 15, 2021. However, according to the governor's update on Tuesday, March 23rd, 90% of all nursing homes across Louisiana have at least started the vaccine series. So this slide represents 3 questions from the survey. Question 5, what is the primary reason that staff members have not received the vaccine? The primary reason was for personal reasons at 96.61%. Question 10 was, what resources are needed to assist with residents and staff to receive the vaccine? Again, the primary reason was others, which included various reasons such as they needed vaccines for new admits and those residents who missed the first and second doses, need to convince staff and residents, education, and limited visits and timeframes in which pharmacy came to administer the doses. That was just a few. Question 4, what is the primary reason that residents have not received the vaccine? And it was for our personal refusal at 83.1%.
You said 83.1%?
Yes.
Okay.
Some of the preliminary findings are related to implementation issues, lack of education, and lack of self-care and burnout. Regarding the implementation issues, administrators found it very difficult to implement policies and changes because of the fluidity of COVID-19 pandemic. Changes were occurring rapidly, and that made it difficult to keep up with the demands and implementation. The lack of education was regarding not only just the COVID-19 pandemic, but also the COVID-19 vaccines. There were multiple messages, and there weren't only a large number of messages, but they were mixed messages. So again, this put a lot of questions and concerns in not only the staff, but the residents and the residents' family members. Also, there was a lack of self-care and burnout. And it just basically was from all the demands of, COVID-19 pandemic and all the changes, everything that was required, working short staff. Some staff had a large exodus out of the facilities. So just various reasons why they ended up with a lack of self-care and burnout. The last slide provides direct quotes from participants. The first quote is, the only thing I can say, forgive me. I know people look at it differently, but when you're in the fire, like we are in my particular building, it doesn't matter what data you send us or what we have the ability to look at when we're sitting there with 50 positive cases at one moment. The second quote was, when you're drowning, all you try to do is keep your head above the water, trying to figure out why you hit the iceberg. The third quote is simple. What is more dangerous for them, meaning residents, the virus or the lifestyle that we force them to live? So at this time, I want to thank you for the opportunity to serve the state of Louisiana. We want to thank each interview, survey, and focus participant. This concludes our part. Any questions?
We can stop sharing. Just to give you a little backdrop before we go into questions, this subcommittee is comprised, I think, primarily of nurses. Aren't most of you nurses?
We do have one physical therapist.
A physical therapist.
One physical therapy and nurses, not by design, but just by you all's experience. And I didn't learn the scope of their work because they submitted the report like everyone else did, but then they continued to conduct a study. They saw what was a recommendation and they proceeded to take action by designing a study and did this all on their own with no funding. And so I do know we have our donors listening, and I'm hopeful that they hear and see the great preliminary work that you all have done. I didn't know the scope until Dr. Bates reached out and asked for like $30 for a subscription to cover some kind of software, and had been, paying out of pocket for a lot of the work. So we appreciate the work that you've done. It's very meaningful, and we'll open up to any questions that, are there any in the chat box?
There are no questions in the chat box.
Yeah, I did have a question, as you might have all come to be accustomed to. So the data you have, you're showing that very high percentages of people are saying that they fail to get vaccinated for personal reasons. But do you have any information that could drill down and provide us more about what those personal reasons are? How are they thinking about it? How we might create messaging to respond to those personal reasons?
We actually do have that, and for simplicity reasons, and so we didn't have 20 slides. We can send you, because people actually did write comments about why they're refusing. So we do have that information. We just didn't have it on the slide.
Well, could you just maybe give a few just off the top of your head? What are some of the reasons? What are these personal reasons that
some of the reasons are related to fear. Some of the reasons are related to lack of education. Those are the primary reasons.
Mistrust, and it's still a concern about the fertility, the infertility situation, and just concerned about that there's not enough information. Still more information is needed, and they want other people to take it and wait to see what happens.
One even said something about a conspiracy with the government. I mean, and wrote out a paragraph about, So.
Yeah, I've been getting a lot of those same answers as I talk to people, and it's really a tough nut to crack to think it through, the risk of COVID versus the risk of the vaccine, and people just they're not thinking that way. So it's a very complicated problem.
Yeah, and one of the other areas that was pointed out was that some of the residents' family members are not willing to sign it.
Yeah.
For them to get the vaccine. So
exactly. Yeah.
So that's a target group we probably need to address, the family members of the residents. All right, if there are thank you again for your presentation. We look forward to, seeing other data as you continue, in your journey with this study, and we appreciate the great work that you are doing. At this time, we welcome Dr. Earl Benjamin Robinson, who will provide the task force with a demo of the work that has been completed thus far on the Health Equity Dashboard. As you know, one of our deliverables is a Health Equity Dashboard, and Dr. Benjamin Robinson has been busy leading this project. We also want to thank him for keeping the task force informed. The emails that you get, forward to the task force, it's all keeping us up to date on LDH webinars and vaccine rollouts. So we appreciate you for doing that for the task force, Dr. Benjamin. So
no problem. I want to say that I'm going to be I'm probably not going to be talking as much because Ms. Kane, who is going to be presenting on the dashboard, is going to be doing a lot of the talking. I'll probably just be tag teaming with her a bit. And so it is her team that has been led the development of this dashboard. And so I just want to say that we are extremely proud to be working with them in development, and we are glad that it is coming to fruition. And so we are working with Secretary Dr. Phillips to get this going and bring it to where it is live at some point. We will be getting final approval at some point, but today will just be a walkthrough. But before we do that, what I want to do is take an opportunity because given the conversation that we just had regarding, there's just a tremendous amount of vaccine hesitancy. I know access is an issue. It remains an issue, and we are working through that. But I want to make certain that people are aware of resources that are available inside the state in relationship to information that the Health Equity Task Force has helped to bring to fruition in the conversations, the conversation series that has come out of the Office of Community Partnerships and Health Equity. And so, and it's going to take me a few minutes to get this. So give me a second to bring this up because we've created on our page a space where all of the COVID-19 conversations, community conversations have been placed on the page so people can go and access them and listen to individual peers from their own community talk about COVID, talk about the facts in relationship to COVID. Some of the individuals who are members of this Health Equity Task Force have been panelists on these discussions. And so I just wanted to make certain that people are aware of the resources that are available in relationship to hearing the facts from people inside their communities who are gatekeepers, sharing factual information about COVID-19. There's a reason why in the creation of these discussions, we have the pictures of individuals who are from around the state on them. There's a reason why we create a one-pager and we put on that one-pager these individuals' pictures, because these are individuals from people's communities. And so thus far, we've executed 4 webinars, COVID-19 vaccine conversations. The first one was a conversation with the African American community. The second one was a conversation with nurses. The third one was a conversation with the faith-based community. And the last one, which took place Wednesday, was a conversation with the Divine Nine. All of these webinar discussions are with individuals from around the state. They represent individuals who are homegrown individuals who are gatekeepers from North Louisiana, Central Louisiana, South Louisiana. They are from and of the community. And so each of these sessions also has a one-pager that speaks to the varied populations that are outlined in these discussions. So that with the African Americans, we talk about the facts, but we also talk about the earned mistrust. And so that comes with the one-pager that we want to be disseminated in the community. With the conversation with nurses, we talk about the facts, we talk about the vaccine's effectiveness, but we also talked about nurses being the most trusted healthcare professionals. With faith-based communities, we talk about the facts, we talk about the effectiveness of the vaccines, but we also talk about churches being places of solace. With the Divine Nine, we talk about the history that the Divine Nine comes out of and doing community service and leaning into them to get this information out there. So I just want to make certain that all of the individuals on the Health Equity Task Force are aware of this resource and are sharing this resource within this community. All you have to do is click the link here and it will take you to the live recording. And in a few days, this will be updated. So you'll see the picture of the event. You just click the event and the recording will start. And right next to it will be its one-pager. And so just wanted to make certain that people were aware that the recordings are here. Please use them. We want people to know that there's information out there that has been created for niche audiences. So please make use of these products. And so without further ado, I'm going to go ahead and turn it over to my partner, Katie. It's been a pleasure working with her. And so we're going to be talking about the dashboard, the health equity dashboard that has been created, and how we hope to use it moving forward to help build communities of response to help work with us to improve health outcomes inside their communities. Katie.
Thanks, Dr. Benjamin Robinson, for the opportunity to share. It's been great working with you as well as our colleagues from the Health Equity Task Force and collaborating on this project. I'm going to walk you through the dashboard quickly, but I'd be remiss if I didn't just take a moment and tell you, why we started working on this and collaborating on this in the first place. So just bear with me for just a couple of slides. And I'm going to try to go really fast and talk high level because I know that we have limited time. So just bear with me here. So I just want to say, so I'm with the Louisiana Department of Health, Office of Public Health, Bureau of Planning and Performance. And we are, so LDH, the Office of Public Health, is an nationally accredited health department. And because of that, we are required at least every 5 years to put out, in particular, 2 documents that pertain to this work. One, or 2 products, I should say, is a state health assessment. So that's something that is meant to really just describe the health of a population and show where the health inequities lie. And then you have a second companion piece to that, which is a state health improvement plan. So this is really your action plan and your roadmap to collectively making health improvements and working toward health improvements in the state. And these are both aimed to be community owned and shared products, not just products of the state health department. So we started doing a health equity or state health assessment dashboard because of our requirement to do that for the Public Health Accreditation Board. And it really worked out nicely that this is something that was also a deliverable essentially from the Health Equity Task Force or recommendation so that could serve that purpose. And I just wanted to say this is not something new. We've been working, our prior iteration of our state health assessment was back from 2016 and it was a PDF, but we're looking to iterate and have an online assessment and dashboard framework to make it accessible and interactive. And I just also wanted to say, why is our state health assessment, why are we saying that it's a health equity dashboard? Well, we're saying that it's because we designed it with a health equity framework in mind. And I just also wanted to call out my colleague who's on this call, Dr. Flint Mitchell, who was really instrumental in developing the design of this dashboard as well. And so this is just, you'll see this in the dashboard. We're using a Prevention Institute framework that describes, first of all, you have to look upstream at the structural drivers and the community conditions. And we're in the dashboard, we're calling those the foundations of community health. And then, further downstream, you have exposures and behaviors. And then all those things ultimately lead to the medical conditions and the equity or inequity that you see. So the dashboard is arranged according to these categories. And I'm not going to go into too much detail here. This is just to say that we also look to this framework to say, okay, what are the indicators that should be, are reflective of health equity? So with that being said, let me pause, stop sharing for a second. I'm going to switch over to sharing the actual dashboard.
While she's doing that, I will say that, with the work group, the health equity work group, we found when we made our recommendations and when we were having discussions with them, that what they were putting together was inside the dashboard that the Office of Public Health was creating. So it worked well with the recommendations that we had when we start meeting together. And so we said, this is a perfect merger.
So I also put the link to the dashboard in the chat so you all can peruse it. And so I'll just give a really quick, as quickly as I can, run a little tour with a couple of caveats. One, just to say that, this is not meant to replace or supersede the voices of Louisianans with lived experience. This is just a place to start with the data that's publicly available. But that obviously has limitations. And so we do want to pursue a community engagement process. And we're in conversation with the Health Equity Task Force membership and Secretary Robinson in particular to see how we can partner on that. So that's just a caveat there. And so it's not the final draft, and because it is a website, it's a work in progress. So you can see we have our health equity, we're explaining it here, the framework here, and the copy is really written to be a 9th grade level to hopefully make it as accessible as possible. So this is just our homepage, kind of talking about explaining the framework of it, why it's important in terms of COVID. And I'll just go through these as quickly as I can. So with this dashboard, we want to be able to have people to be able to access data, statewide data, but also local data to the extent possible. And so we have pages that represent statewide data, or you can go specifically to pages that represent your OPH, your region of the state. So this is kind of a key to which region means what. And this page, if you're in region 1, you can just go quickly to data pertaining to your region. We do have a page, before I get into show you the visualizations, we do have a role about, how people can, a page about how people can use this, why it's important, how you can start taking action now, and a link to let us know if you have feedback. Okay, so getting into some of the data, and before we even get into, the health or health-related factors, we have a page about demographics. And so, you can peruse this as you would expect. It's, age, race, all that stuff. I'm describing the population, but we're also, we have a kind of a key to rural versus urban, because we, in the analysis that's gone on behind the scenes here to really identify where the inequities are. A lot of inequities are rural versus urban. And so this page just kind of shows what we mean by that. But of course, a lot more demographic information can be found. You can scroll that page. The Foundations of Community Health page is really where we dive into those, community factors, those structural determinants, what sort of opportunities people have with regard to whether it's early education, incarceration rates, income opportunity. We have some ALICE data here. So there's data, a lot of the data here is from publicly available data sets, Census, American Community Survey. A lot of it's from the CDC, various data sets that they have. But we do have some locally generated data sets in here too, like the United Way ALICE data. And again, so much in here. And one thing I want to say, for example, this is information about housing. You can see these little drop down arrows. There's so much more to this website than meets. So you can click on the drop down, for example, if you want to see excessive housing costs by parish, you know, and it'll have different visualizations here. And it'll pop up. So there's a lot you can really explore. In this case, it's the darker represents housing units paying 30% or more of income on housing. And I also wanted to show you with all these visualizations, you can download the data. If you click on this link here, you could get a CSV or a JSON. You can also export as a picture, export the map as a picture if you want to pop it in a PowerPoint presentation. And if you want to link out to this in particular, you can get a link to this particular part of the dashboard by clicking on that little link. So we have a lot of information and behaviors, exposures, obviously, but medical conditions, I'll just share for another minute and then I'll hand it over. We have, again, so much information in here. This is information on health outcomes from the county health rankings. You have life expectancy data here by parish, even causes of death data here. And again, so much more data here. For example, physical health, you can get any of these by age, sex, race, education, you know, heart disease and really kind of broken down by all these different demographic areas. So you can kind of see for yourself, you know, where are the disparities that exist in heart disease deaths in, you know, by race, ethnicity, by parish, you know, and a lot of times we're showing trend lines as well. And I'll just show, for example, the final point I'll make is that, you know, we're limited by the sample sizes in terms of how granular we can get with this data. But if this is just particularly to show you region 2 medical conditions. And so life expectancy, for example, you can see by parish, by race, we have it here. And even by, this is one you can get by census tract if you're in the regional area. So again, that's just a little, as quick a tour as I could possibly give, but happy to, you know, follow up with anyone that wants to dive deeper. I get more information. So I'll hand it back to you, Dr. Benjamin Robinson.
So thank you so much, Ms. King. And so this website will at some point be released once we get approval from Dr. Phillips. One thing that will be coming out of my office in association with this, and also be done in partnership with Katie's Bureau, is that we just don't want to put this out and just say, okay, it's here. What we hope to be providing is some sort of educational and training with it for the community so that individuals are aware and know how to use it. And so there will be a training and workshop component for community to help build their capacity of how to use this tool so that they can, when they identify issues inside their community, they can go to this dashboard and find it useful and use it to rectify or deal with matters in their respective communities.
I think Katie has posted in the chat box the access, if you all want access to the demo and the password, so that you all can go in and peruse it. And if there's any suggestions that you have, you know, please forward it, because it's being built as we speak. And the design is something that the subcommittees have asked for, which was that it was a one-stop comprehensive shop that housed all the data for the state of Louisiana. And I think you all have done an outstanding job with that.
Thank you. And just one side note before you guys know is that we have to be careful about the amount of data we put inside of it. One of the things that my sidewalk made clear, the more information you put in it, it can slow it down. And so we're very, very strategic about they've been very, very strategic about what is there. And so we just be mindful about what, a lot of thought went into what is in there in relationship to, does this really need to be there? Because we didn't want to slow it down. We want to make certain that it remains fast so that people don't go to it and they're like, I'm waiting on 5 minutes for that button click. Is there anything else, Katie? Is there?
I think.
Oh, Tracy said she's shared the link with everyone via email. So that link will come straight to your email.
Okay.
Yeah.
I guess I'll just say that I really hope that this is a foundation, and it's not the be all end all, it's just the first step. And so, we are planning, hopefully, to do a community engagement process, and then a process. We're also building right now, we're designing with our partner, My Sidewalk, a state health improvement plan site. So a companion site that can hopefully lay the foundation for collective plans to really address, some of these disparities and inequities. So, that's kind of the hope and the longer term vision. So more on that to come.
And so we've received a proposal for funding, a request for funding to assist with the building of the community engaging piece from LPHI. And so we thank the donors for funding what we have to get us to where we are today. All right, and next on our agenda, we have another subcommittee that meets weekly, where great minds come together and they use art and science in developing impactful messages as they listen to some great music while doing it. And they meet every Thursday morning. And so we welcome the Dr. Derek Riveras, the co-chair of Communications and Messaging Subcommittee.
Thank you, Dr. Brown. And yeah, we have been meeting regularly and we meet early. We have decided that this messaging is so important. And so I've got just a wonderful committee. I'm going to share my screen in a very quick PowerPoint with you because the hour is late. So if I can do that. Are we on the same page? Okay.
Yes.
So this is the Communication and Messaging Subcommittee. I know we've got some folks in the audience who may not be familiar with this subcommittee, but as was mentioned, we meet regularly on Thursday morning, early before we start work. Ms. Lenore Carroll, who is an administrator with the United Home Nation, Drs. Keith C. Ferdinand and Dr. Corey Hebert, who are legendary physicians in the greater New Orleans area. Both have significant experience working in health disparities, and both have national outreach and marketing in terms of getting the messages out to folks. Councilwoman Helena Moreno has been represented very well by Sadie Finkel, who is on the call today. Councilwoman Cindy Nguyen, myself, Ms. Janine Tate is responsible for so much of the communication pieces that you see. She is at Southern University and she is leading the charge in putting this stuff together. Our own Dr. Brown has been meeting with us as well as Dr. Levis. And so it's very clear that we've got to get the messaging out after listening to the presentations earlier, without letting people know how important it is to engage in healthy practices. There's no way we're going to be successful. So we can collect all the data that we want. We don't get people actively engaging and start breaking down some of the myths that are holding people back from getting vaccinated. We're going to fall short. So here's a quick snapshot. We continue to use paid media, including billboards, cable TV, and social media. I'll give you some data on the social media outreach. But our emphasis now has switched to vaccination. We're going to continue our messaging and our brand awareness with hand washing, social distancing, and physical distancing and mask wearing. But we're focusing on taking the shot. We started a campaign way before anybody else with "It Ain't Over," and letting people know this was back in September. When people are starting to, it's been a journey, as David mentioned. It feels like decades, But back in September, people were starting to wane and getting too comfortable. And we're seeing that again now with the vaccine, and people are thinking it's over. And so we're continue reintroducing that campaign, as well as you got to take the shot. Our locations haven't changed. We're still putting billboards out in Baton Rouge, Houma, New Orleans, Shreveport, and we are just now starting to work with Alexandria, Lafayette, and Lake Charles, those areas that were hit pretty hard by Hurricane Zeta and a couple others. We have hit the end of our reach, though, in terms of funding. And so there's a great need for us to continue this messaging, and we're going to need some additional funds to get the messaging out. Here's an example of one of those pieces.
I want to get a vaccine, but are they safe? Yes, all are authorized by the FDA. Okay, so which one should I get? Yes. No, which one should I get? You should get whichever one you can find. Okay, cool. Now I can go schedule my appointment. Wash up, mask up, separate, vaccinate.
And our messaging has been very clear and very succinct. Wash up, separate, vaccinate. And we're trying to get the message to folks in ways that they can receive it. And one of the things that we've done, I'll talk about in just a second, we partner with LDH as well to try and get more messaging out. We want to make sure that the messages resonate with the folks we're targeting. And so with due respect to the good doctors that you see in the video, we're not using Madison Avenue model type folks in our advertising. We're using the folks that you will see and the folks that you might recognize in our ads. Here's a second one.
So the numbers are going down and you think it's over, but it still ain't over. There's 4 things you got to do.
Wash up. Wash up, mask up, separate,
Vaccinate.
wash up, mask up, separate, vaccinate.
And so again, you can see the succinct nature of the message. 30-second spots. We're using social media and hopefully able to expand to TV as well. Here's some one of the billboards that we're using, and this one is as you can see, the 4 images highlighting the wash up, the mask up, the separate, and the vaccinate. And we're hoping to be able to replace the ones that are expiring at the end of this month. Next week we'll have exhausted our media buys, and so we're going to need some additional funding to get this to continue these messages, especially the notion that it ain't over. Our collaborations continue, and Noopsy has mentioned this Divine 9, and so part of why I got my colors on. We're going to continue to spread the message every way we can. And we've partnered with LDH on the other 2 webinars, and again with this one, trying to make sure that people can attend. And if you didn't get a chance, the last ones they've been very, very informative, and I don't doubt that this one will be the same. So we will help spread that message. Our reach, we've been at this for a while. And we want to know if we're making a difference. If you look at the blue line, the organic line, it's rather flat with a little blip at the end. But when we look at those paid social media outreaches, we see an uptick of almost 71,000 hits. And so this stuff costs money. I can't say it enough, but we're going to continue to put messaging out that reaches people where they are. An example is our 3rd bullet, where we talk about street level billboards and bus shelters. We know that the billboards that we have now are typically seen by folks in their own personal vehicles, and maybe on public transportation. But we know that a lot of our community members are not vehicle owners, and so we want to make things available for those who do use public transportation. Putting street levels billboards is just a no-brainer when it comes to reaching the folks that haven't been reached so far. And then we want to do more messaging. That again is our target. So you can reach us obviously on Facebook, Instagram, and YouTube. Those are our addresses. And you will see more of this social media piece that that I just referenced. I know that we also plan to translate all of our work so that we have it available in Spanish and Vietnamese where necessary. And we're going to continue to partner. We're going to continue to partner. Tomorrow I'll be joining the Baton Rouge General vaccination distribution as part of the 100 Black Men of Greater Baton Rouge as we do some vaccinations in Gloryland Baptist Church. Those are the ways in which our committee has stepped up and reached out, and we've done it as was mentioned before, not just with emotion, but with science. And so we're driving the message with science, and we're doing it in a very succinct, simple way, not beating anybody over the head and not trumpeting or thumping chest. We're simply trying to get messages out. Lastly, I'm going to be followed by Secretary Robinson, who's probably scratching her head now saying, oh my gosh, they need more money. But we need more money. Thank you all.
All right. Thank you. Thank you so very much, Dr. Riveras. And thank you for the great work that your committee is doing. At this time, we would like to present our very own Secretary Kimberly Lewis Robinson, who will give us an update on our funding status. She holds the purse strings, how much money we have, how much we need, how do we turn a nickel into a dime. So we'll turn it over to Secretary Robinson.
Thank you, Dr. Brown. And Dr. Riveras, you are right. There is no money. So the total budget that we started with was $750,000, and we have managed to spend $750,000 with the task force. We have a few things that are in the works. So the presentation on the dashboard from Katie Kane and Dr. Earl Benjamin Robinson, as they mentioned, the community engagement piece that would be underway. That is $130,000 that would be going to the work of LPHI, Ms. Shalina Davis, who's looking at me like, what? So that is money that would be expended on that. The nursing home subcommittee has already spent $30 on transcription services. That money is coming back to you, Ms. Bates, Ms. Alicia Bates, and they have submitted a budget request for their nursing home administrator survey. That would be approximately $14,700 that we will just be able to pay for with the funding that is left after the health equity dashboard process is underway. So that.
Thank you.
You're welcome.
Thank you so much.
And I have made the pitch for funding to our initial funders, the Baton Rouge Area Foundation, the Pennington Foundation, and the Huey and Angelina Wilson Foundation. We did that last week. We presented the dashboard as well as our plans for future projects to them. And I've also made the same request to my counterpart, Secretary Phillips, for additional funding from the Department of Health's allocation of funds under the American Rescue Plan, and the same request to the governor for funding from the state's allocation of funding under the American Rescue Plan. So between all of those, hopefully we will have additional funding within the next 60 to 90 days to spend on some additional efforts. Knowing that the state has not received its funding yet from the U.S. Department of Treasury, and we will be waiting for, one, the Treasury to announce how they're sending the money to the states, but we're also waiting for guidance on some of the details. There are a few things tied to that $3 billion, including the ability of the state to make changes to the tax code and reduce revenue that some of the members of the legislature are interested in. We're not interested in it, but they are. So we have to know the rules to follow for doing that. And then some of it will have to be appropriated. But I did have the conversation with the governor, so he intends to make sure that there are some funds available to continue the work of the task force. So we should have money at least by the end of this fiscal year, since that is probably somewhere in the neighborhood of 60 to 90 days out. And I think that the other thing, thus far, we set aside some money for the webinars that Dr. Benjamin Robinson has been putting on. It was set aside at $7,500. I reduced that to $2,500. You lost some money, Mr. Robinson. I'm sorry. I have to pay for the nursing home subcommittee survey. So you lost some money.
At least you got some, bro.
We appreciate.
So we talk about how much has been spent by the subcommittee on communications.
We certainly can, and we're going to continue to spend as long as you get it to us.
So yes, don't start. I have been very generous to you. Don't you start.
You have indeed, but my hands are still out.
So that is the only other change to be aware of. We did cut that so that we can start the nursing home subcommittee administrator survey. So with that, we truly have no money left. Please understand, we are technically negative $275, but I'm not expecting Mr. Robinson to spend all of his money.
All right. Thank you so much, Secretary Robinson. Are there any questions about the budget? I think you gave a very thorough overview, and we appreciate your work with us. Tracy, are there
for all the other money? So hopefully some of the additional money starts coming in soon.
We're hopeful. Are there any public comments, Tracy?
No, ma'am, no public comments.
Okay. Before we adjourn, any words of wisdom, Dr. Levis?
Well, I'm not sure how much wisdom there is, but I do have a few words of thanks to everyone on this task force, and a special thanks to the subcommittees that have been working so diligently, such as the Communications Task Force, the Dashboard Task Force, and also the nursing home. You've all done excellent work and made an important contribution. Thank you all.
Thank you. All right, we are shy of 3 minutes to the hour. Thank you for attending the meeting today. As you can see, we have much work to do to get to the other side of this pandemic. Our commitment to equality is what unites us as brothers and sisters and defines us as a task force. So we are in this pandemic together, and we have to get out of it together. So with that said, thank you all for joining us today. Have a blessed Easter. Oh, take us away, Dr. Rivera.
We're going to take you out with the theme for this evening, my last $2.
One for the bus fare, the other for the jukebox.
And one for the communication committee.
Thank you, everybody.
Derek, you still got time to go and change that shirt, man.
Wait, what would you want me to change it to, bro?
I don't know. Me and Flint will wear one time and show you.
Yeah, let's wear some red. We can wear a little red, a little crimson,
and cream to show you a little bit.
Y'all probably have to share that shirt. You know how y'all do. Y'all.
Well, I'm gonna have to pull out my red and white. I'm gonna have to pull out my red.
Hey.
But don't y'all start with no problem with the red and white. Go ahead.
There you go.
No, that's right. That's crimson and cream. That's a family right there, man.
Oh,
yes, it is.
Might have started something.
Y'all have a good
weekend.
Dr. Brown.
Yeah.
Dr. Brown, I sent you a message the last time we were on.